Physicians often feel their responsibility to dying patients is simply to provide good medical care. But increasingly, they're being told that they should do more. And our medical editor, Dr. Tim Johnson, is joining us this morning with the story of a remarkable physician who is doing more for terminally ill patients, and for a very good reason. Tim, good morning.
Well, as you know, Charlie, the doctor with whom I recently sat down in Chicago is himself dying. And because of that, he's found he now has some special insight to offer other doctors. And he's been doing so with both deeds and words.
For the second time in my life, I face the prospect of premature death. Barring a miracle, I have few doubts about the outcome, but I am not afraid. I know only months remain.
As a critical care physician for nearly 30 years, Dr. Roger Bone learned all he could about dying patients. But now, dying is his own reality, and he is recording his final journey in a series of moving personal essays published in the Journal of the American Medical Association.
One of the things I have learned from the process of my dying is that the most important things in the process of my living were not what I, and most others, usually think are important.
The author of numerous publications and the recipient of some of medicine's highest honors, Dr. Bone had already faced the prospect of dying before. As a young Army surgeon in Vietnam, he helped remove a live 40-millimeter grenade from a soldier's abdomen. Bone survived, and for putting his own life at risk to save another, he won a Medal of Valor. But now, the time bomb is inside his body.
No life is without gift, even when it may seem giftless to others. Cancer has allowed me a measure of enlightenment.
The cancer, in this case kidney cancer, was discovered 3 years ago. The tumorous kidney was removed, and Bone believed the danger had passed. But 10 months later, the 55-year-old father of two learned that the cancer had spread to his lungs and bones. Determined to beat it, Dr. Bone began aggressive experimental therapies as well as conventional treatments of chemotherapy and radiation, which he still undergoes daily. His survival has already defied the odds.
Most patients with renal cell cancer, they may die from 1 to 6 months. Now, we're talking about 3 years later. I'm still alive, and I think part of that is because I'm not going to let myself die. I'm going to go down fighting.
One option is what we can do is do a complete rotation, but we don't spare the spinal cord at all. And
because he takes daily doses of morphine to ease his considerable pain, Dr. Bone no longer practices medicine. And with a large tumor circling his spinal cord, doctors say he will likely become paralyzed. But for now, Dr. Bone spends his days at the hospital writing and counseling other terminally ill patients. Can you remember how you used to approach terminally ill patients in your medical practice, and how you do it today, and what's different?
I took care of the needs, the medical needs of the patient and the physical needs of the patient, but I don't think I was emotionally involved as much as I should have. And I think the medical profession needs to be much more emotionally involved.
Equally important, he says, is helping the patient communicate his or her fears and needs with family members. His most effective treatment, he says, has been the time shared with his wife, Rosemary, and with his daughters, Mary Catherine and Cynthia.
This is a time that he could be totally introverted and only think of himself. And he is thinking of the patients and their families and what they are dealing with. And I really admire that, because I don't know if I could do that myself.
He really has a message. He has things that he wants to tell us, and we want to get as much out of this time as we can, because this is the legacy that's going to live on, and this is what's very important to us.
My father never told me he loved me, I'm sure he did, but he never told me that. So that's been very important to me, to make certain that I don't know the millions of times I've told my children that I love you, so they know.
You're looking good, though.
Well, I'm working on it.
Good. Hair is coming pretty.
The hair is coming in. I don't know about pretty.
As for his legacy at work, Dr. Bone has convinced Chicago's Rush Presbyterian Hospital, where he once served as dean, to create an institute for the education and study of the dying patient.
He's the only one that I know of who has, through his own confrontation with death, turned that to try to influence a whole profession to deal with this issue rather than escape from it. And that's a great contribution.
I think it is very important that the doctor and the nurse and the health professional recognize the emotional aspects that someone who is terminally ill, as I am, goes through. I think one should ask the patient, do you have peace of mind about what is going to happen to you after your death?
What do you say to your fellow doctors who say, well, it sounds great in theory, but, you know, we're so busy, managed care is forcing us to spend less and less time with patients. I've got to leave that up to other people whose job it is, the ministers, the social workers. I just don't either have the time or the emotional resources myself to do it.
It's no excuse whatsoever. And we're talking about life and death. We're talking about peace at the end of your life. Are you at peace? Is there a more important question to ask at all, you know?
Dr. Roger Bone, Tim, I think many viewers know, is a minister as well as a doctor. Tim, is he saying there's a time when you have to shift the emphasis from the medical care to the spiritual care?
I think that's precisely what he's saying. He believes that there is no person who has a more persistent or pervasive presence in the life of a dying patient and in the family's life than the doctor. And at some point, certainly, the physical needs, other than making sure there is no pain and suffering, become secondary, and the spiritual questions become primary. And what he's saying is that the doctor should become a facilitator of that spiritual exploration.
But when you find something wrong with the gallbladder, you bring in a gallbladder specialist. When you find something wrong in cancer, you bring in an oncologist. Why not just simply bring in the clergy?
And he certainly would agree that that person can be very helpful, but he thinks the doctor should play at least a role in making sure that that happens, in letting the patient and family know that it's important for them to explore those questions, letting the patient and family know that he or she as the doctor will be glad to help in that process, get the right people to make sure those questions get addressed.
Dr. Bone very movingly said, as I approach my own death, I find I want to live, and I want to use these months to live. But as soon as the patient or the family sees the doctor shifting over to spiritual needs or bringing the clergy in, might they resist, saying, no, 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 you're writing me off. You're beginning to say, no, I'm a lost cause.
It clearly depends on how it's done. If the doctor simply abandons the patient at that point, of course that would be the reaction. But what he's saying, one of the things he's learned that I think is remarkable is that the dying person doesn't just shrivel in on themselves, but instead starts to seek more than ever outside help and resource and contact. That's what he's experienced. He's found that as he's opened himself up to other dying patients. And he says the doctor may indeed shift care at that point, but should continue to be a real and persistent everyday presence in that patient's life, and that's what he's trying to tell other doctors to do.
And I gather he's putting together a manual of things that dying patients ought to consider, which they're going to make available. I hope we have a chance to talk about it.
Oh, it's a remarkable document, and when it becomes available, we should let people know how to get it, because it's one of the best things I've seen.
Hello, I'm Dr. Bart Chernow. On behalf of the American College of Chest Physicians and its Chest Foundation, I am pleased to introduce you to a new videotape series entitled A Physician's Perspective. This series of tapes will present the opinions and insights of colleagues regarding issues which confront practitioners and physician scientists involved in diseases of the chest. In this inaugural videotape, the physician's perspective is presented by Dr. Roger Bone. Dr. Bone is a past president of the college and is one of the most distinguished physician scientists in the world. As a specialist in pulmonary and critical care medicine, he provides us with his insights regarding dying. At the time of this taping, Dr. Bone is suffering from metastatic renal cell carcinoma. I think you'll find his insights and his interchange with Dr. Claire Panosian to be remarkably frank, and I hope that you will gain, as I have, from watching this videotape. And now, a physician's perspective.
Hello and welcome to Physician's Perspective, a series of interviews with distinguished members of the American College of Chest Physicians. I'm Dr. Claire Panosian. The psalmist once wrote, "As for man, his days are like grass. He flourishes like a flower in the field, then the wind blows over, and it is gone." Dying is a natural part of life and a natural part of the practice of medicine. In the midst of an acclaimed academic career in which he himself cared for thousands of critically ill patients, Dr. Roger Bone was diagnosed with kidney cancer. Since then, he's shared candidly with our profession about dying and living. Dr. Bone, thank you for your candor. Thank you for your example. Now, Elizabeth Kubler-Ross has said that we're a death-denying society. Have we also become a death-denying profession?
I think so. I think all of us want to live as long as we possibly can. I think the medical profession is no exception to the rule. And I think the medical profession is really not well trained to deal with a dying patient. We do deal with the last days. We try to be as compassionate as we possibly can, but we don't do everything we possibly can do, I think, to try to make the patient as peaceful as possible in those last few days.
Well, you've taken quite a journey, and you're going to share the journey, but the beginning, I think, for our profession was when you published a piece in JAMA, Taste of Lemonade on a Summer Afternoon, February '95. Can you describe the circumstances that led to that?
I recognize that kidney cancer is a very serious cancer, and if I got metastatic disease, we would have a very rough time. So I recognized how serious the problem was. I then wrote in JAMA some pieces about how my life had changed and how I had emphasized all of my life the academic, the clinical, and all of this part of medicine. But I wanted to emphasize that to the medical students that there's 4 issues that they really should think about too.
Well, let's list those, because those were very important in that piece. You said that these were lessons from the very beginning.
Good health is taken for granted, and I don't think it should be taken for granted. Every day that you have, this is important. So you don't really appreciate it until you don't have good health many times. So that's important. Second, I emphasized how important the family is in order to get through such an experience, the family unit. Then I emphasized really how important God is in getting through this experience too. So that was the third thing. And then fourth, I emphasized that things that we think are so urgent many times are not even very important. We're so involved with our day-to-day life that we don't deal with the big picture, and there is a big picture out there. And I wanted to emphasize to the medical students at a convocation, and the piece that I wrote was at a convocation, that we need to emphasize these things more. Read a good novel, eat a good dinner, appreciate it, do more than just be a good doctor. Being a good doctor is very important, but it's very important to appreciate the other part too, so one can be a full, rounded physician.
What was the reaction from the medical students and then from your colleagues who read this piece?
From the medical students, hardly anything. It was just someone, the president of the medical college was speaking on a stage about something, and they hardly did anything. But from my colleagues, it was very different. I got thousands of letters after I published this piece, and it was unbelievable how much impact that made on my colleagues, because they felt, the medical student really doesn't know what they don't know. And the colleagues who are out there know that they really weren't taught, and they really know there is a deficiency in this, and they want to get back to understanding what I was talking about. And every one of the pieces, there was not a one of the letters saying, I disagree. They all agreed.
You opened a floodgate, I
There
believe,
was a floodgate, yeah.
of responses. Well, then let's also talk about some literary examples that you used in the first piece. A wonderful example from Thornton Wilder's play, Our Town, the character Emily.
Yes, let me tell you a little bit more about Our Town, because I think it is very important, and give you some of the people who are there. George Gibbs is the doctor, and the doctor delivers twins in the play, in the first part of the play. So birth is the first part. George and Emily, now they live right next door. Emily is father is in charge of the newspaper. So George and Emily play through high school and then get married in Act 2. Marriage is Act 2. Death is Act 3. And what happens in Act 3 is Emily dies at the age of 26 years old during childbirth. And Emily then comes back as a spirit and looks at what is happening in Grover's Corner, Connecticut, which is a mythical New England town, and says, they don't really understand, do they? They are letting life pass them by. They're not smelling the roses.
And this is a message for us in medicine.
That is a message for us in medicine. And I'm not saying to be frivolous, but I'm saying it is very important to appreciate life while life is bestowed upon you.
Roger, you've also been very influenced by Thoreau, and a specific line showed up in that first JAMA article.
Yeah, Thoreau is really a personal hero for me. Thoreau went to Walden Pond. He did this over a period of 2 years. In the book, it looks like it is 1 year, where he went through 4 different seasons. It's very important because he went to Walden Pond really to find his soul and to find serenity. And what he said, and what I quoted in this piece, is man lives a life of quiet desperation most of the time. And I think that is so true. One needs to emphasize that that is true, and one needs to try to avoid that quiet desperation that takes place.
You have been someone who appreciated and loved nature all your life. And in medicine, we would think that we would be very closely attuned to nature, but I'm not sure that's true. How should doctors be taking advantage of lessons of nature? What have they taught you?
I've loved nature all my life, so there is no doubt about that. But after my cancer diagnosis and after the diagnosis of metastatic disease, I live on a place called the Maumee River, and that's my Walden Pond. And so I have really taken my own, what I've said literally, and my wife and I and family really have enjoyed every flower, every bird, every piece of nature that we can see is a joy to us. And that is part of the points that I made before when I went through the 4 different things, that one has to enjoy life. And I think nature helps you find serenity in life. And nature is part of medicine. And I think that is we should go back to nature.
You have been very poetic about the Maumee River. I'm wanting to see the blue herons flying. Do they fly all seasons or just certain times of the year?
Really, certain times of the year. We have a tree that is an old dead tree that the blue herons come and sit on the that dead tree. And Rosemary and I go down and look at that tree and the blue herons there and the ducks that are down there as the little baby ducks and the larger ducks that are there at the same time. It is a beautiful river that we can, believe it or not, we can see 3 sunsets. And what we do is we go to the bottom of this, we see the sunset, then we go up, and then you can see another sunset, and then we go up the stairs a little bit more and we can see the sunset again. So we see 3 sunsets every sunset. So we watch the blue heron, look at the ducks, see 3 sunsets, and then go back and have a steak or something.
Sounds good. Does nature also help us find serenity in facing death and dying?
Well, I think it really does. Rosemary and I go back to our Walden Pond whenever we can, because that is essentially how I can communicate. It's how you communicate with creation, and you understand creation a little bit more if you go back to nature, because that is the example of creation and how it is at this time. So I do everything possible to spend every moment that I possibly can in nature.
I'm going to fast forward to the next piece that you wrote for JAMA, which had a more serious fact that you presented, and that really brings us to your medical condition at the present, but Another Taste of Lemonade, December
yes,
95.
The December piece was a very sorrowful piece, because that's when metastatic disease, widespread metastatic disease, was diagnosed in my lungs and in my bones. And even since then, I have had failure of medical therapy. So this has not been a good chapter as far as what has happened to me since renal cell carcinoma was diagnosed. Essentially, the worst possible has happened. Metastatic disease that has not responded to therapy. The second piece, I really re-emphasized what metastatic disease, the impact that made upon me, the impact that made upon my family, but I did re-emphasize everything that I said before in the previous piece, and that's what helped me find peace in the dying process. I mean, just to put it bluntly, all of us are going to die. The question is just when. And all of us have to face that dying process. And I am fortunate in certain ways in that I have had time to think about all of this, to go to nature, to go through the process where many people will have a myocardial infarction or a stroke and die just acutely and never have that opportunity to have a reawakening in their own life. So I think it's very important to think of it that way.
You faced the possibility of a premature death when you were a young Army captain. You were a medical officer in Vietnam, and you removed live grenade, part of a team that took this from surgical abdomen, and there was a possibility something terrible might have happened to you. So that was a fearful experience.
Yeah, that was fearful, but it happened so quickly that it didn't even register, So it was just one of those things, and it was a workaday world, and there was a live explosive. And what do you do when there is a GI there that has a live explosive in there and he's dying? You try to take care of him. So that is much different from a chronic dying process. It's very different, I think.
What about fear now? We all have it, but we don't talk about it. Maybe you can share something.
Fear is great now, and you often feel like you have peace today and you don't have peace tomorrow. You see what I'm saying? It's not something that you continuously have and you can say, okay, I got it, okay, it's mine, there's no fear. And I can't say I can't say that I'm totally at peace. I can't say that I have no fear of what is going to happen, because I do. And I have relative amounts depending on the day that we're talking about, because of the process that is taking place in my body. So I think it's something that needs to be discussed, but when you start talking about peace, that peace is a relative peace. One thing that my wife and I often do, is read the Bible and do a lot of things together like that, trying to find that peace that takes place. But it is a peace that is not, it's not steady. I would be very surprised if anybody told me that's going through a process like I'm going through, that it's steady for them.
Well, I think you're giving a lot of people comfort by saying it, because sometimes it's held out as something achievable, and yet it seems so much elusive to a human being who's naturally going to have an emotional fluctuation, even somebody who has great faith. Mm-hmm. You've also stressed the need at times to be alone. Not something that we in medicine experience too much. We're very much among others.
Well, I think solitude is very, very important. And the type of solitude I'm talking about is, and this is the solitude where you just, you have all of your friends. I mean, so that's fine that you have friends that care, but at the same time, it is very important that you be your own captain, and that you go where you can be alone. And like I said, where I want to be alone is with nature, with God's creation, and appreciate what is happening in the world, from my perspective, in God's creation and in nature. And that's where I go to be alone. And that's not solitude. That is all worship, essentially, worship of creation. I think it's very important, and it's been very important to me. The process one is going through is very difficult, and it is very personal. And it is something that someone from the outside can't help you that much, because there's not that much known. I did emphasize that the family becomes very important in that unit.
Well, overall now, there are really some very important lessons that have come from this journey, and it seems to me that there's a lot that you've been able to share with your colleagues and encouraging them to live their lives with this appreciation of the preciousness of life and the priorities. But also, you've been very sensitive to the needs of dying patients. How did you change? You had always been, I think, a very sophisticated teacher, a bedside clinician, a researcher in illnesses that were life-threatening, septic shock, and yet you have a new perspective. How is it new? How is it changed in terms of a dying patient?
Well, very much so, in that I was not trained any more than the medical student is trained today in large part. So I took care of the patient's physical needs. I took care of the patient's social needs. If the patient needed a religious counselor, I took care of that. So I took care of the patient in a pulmonary critical care unit, and I thought I did it very, very well. And I was very happy, and I was very pleased with what I was doing. However, I never went in and said, are you at peace, with what is happening at this time? And I have done that. since I've had metastatic disease. In fact, I've made weekly rounds at various intervals when I wasn't so sick with chemotherapy. And I have gone to the bedside and I've asked the patient, how do they feel and are they at peace, and that I am a physician that probably has a terminal illness. Would they like to talk to me? Number two, I would be very happy to share with them my own perspective about this, and we could talk about this journey that we may be taking together. So I think that is helpful to go that far. The other thing that I have done is establish or tried to get Rush Presbyterian St. Luke's Medical Center, which they have agreed to establish an institute for the education and study of the dying patient. So I hope there will be an approach at the medical student and resident level that will allow us to understand the dying patient and how can we deal with the dying patient in a more appropriate way than we have in the past.
It seems to me that some of our attitudes about dying patients are formed even before we go to medical school. It has to do with the values that we're taught at a young age, attitudes, and to be empathetic.
I think we are empathetic. So what I'm talking about is not empathy. And as a pulmonary and critical care physician, I was empathetic. The issue is one step further than empathy. The step is, does the patient appreciate where they're going and the journey they are going to take, and should medicine be involved in helping them in that journey they're going to take? And if so, how can medicine help them? And my bias is there'll be many ways. There would be a spiritual approach. When I've gone to patients, many times when they said they're at peace, they will give me a spiritual message. They will talk about a spiritual approach. But that is not the only approach that will take place. That many patients will find peace. And what I think medicine should do is not necessarily say this is the way that you should find peace because this is the way it is, but one should give alternatives.
Roger, do you think that there are some misconceptions that physicians have about what a dying patient would want to talk about, and that's part of the problem?
Oh, I think there are various misconceptions. I think the physician is scared to talk about the process, for one thing, because they're going to be asked questions they can't answer because death is something that we don't know a lot about. So there's that fear that is there. Also, there's the fear of failure. If you're talking about dying, then your prescribed treatment modalities must not have worked. And so the physician may be uncomfortable talking about failure of the treatment that they had hoped would have worked all of this time. So I think the physician has problems there. But I think the biggest issue that the physician has is the process of the unknown. And that's what we need to do. We need to become comfortable and recognize it's okay for things to be unknown. We're learning every 3 to 5 years, we're doubling medical knowledge. So there's so much that is unknown out there, it's unbelievable.
You're really speaking about a quality that isn't mentioned often in medicine, and that's humility. And I'm wondering if with all of the high-tech advances that somehow physicians have forgotten humility and that vulnerability of not being able to answer every question. Should we have mentors and teachers in the training process, maybe not even physicians, but from other professions, who can guide us in these ways?
I said I got thousands of letters after I wrote those pieces, and many of those letters said they were mentors. They said, I agree with exactly with what you say. This is not being taught in medical school. I have, and it's not any inspiration they got from my piece, they had said to themselves that they're going to spend the rest of their career spending a lot of their time helping the medical student and resident understand this issue. So they have volunteered to become mentors. I think there will be more institutes that will be developed. I think the pulmonary and critical care community will be more and more involved with this process, because it is something that impinges on the pulmonary and critical care community so much. It is something that I think will more and more be involved in the process. So I agree we need humility. We need humility to appreciate the process. I don't think it's the major problem that is taking place. I think the truth is the physician does have humility about death, because the physician knows how little they know about the death and the near death and the dying experience.
But the communication skills, even among our own profession, may be lacking. This is where I feel that your example is an outstanding one.
Well, I agree totally. The communication skills is the real issue there. Then getting to the patient, okay, after you understand what there is to understand, you are educated about all alternatives that are available out there. You have an appreciation of the process that is taking place. You understand the way different people go through the grieving process. So once you understand this process that is taking place, then you have an appreciation, a better appreciation of how to approach the patient, how to communicate with the patient. And I agree with you totally. It is communication, so that you can give what little you know. And that's a very humble statement. What little you know about the process and the journey that is going to be taking place. But at least you know, you know what they're going through and what people have written about who have thought about this for a long period of time.
Would you be willing to talk about the teaching hospital as a specific setting? Because of course that's often where the most high-tech medicine is being practiced, and frequently the fewest role models, in fact, because everybody is very much oriented towards their field. They're striving to do something, maybe research oriented, but in any case, there is a tremendous emphasis on the curative as opposed to this compassionate comfort.
Yeah, that may be so, or it may not be so. And for example, a teaching hospital can have an ethics consultation service, a religious consultation service, a social consultation service, you know, and on down the pike. So in a teaching hospital, there may be greater challenges, but there may be greater ways to solve those challenges too. Because you have so many more resources available to you to do so. The teaching hospital has a tremendous opportunity and has a tremendous challenge, but can botch it up terribly if it's a subspecialty oriented type thing where you don't have a coordinated approach to the process.
You know, Kubler-Ross talks about certain patients who may be at risk for suicide, dealing with serious and terminal diseases. And she raises one category. Of course, she makes the point that it's very wrong not to provide hope. But she also talks about patients who have been given unrealistic hope. And I'm wondering if there are any examples that you might comment on, or just to reflect upon this thought in general, of whether we do our patients a disservice sometimes by emphasizing something that may really not be that realistic in their case. Is that something we need to talk about?
It's a fascinating thing that you're talking about, because it's actually at the process that I'm at right now. That I have gone through 4 different phases of chemotherapy. And as far as medical science is, I'm out of options, okay? I don't do anything else, or I think about alternative medicine or other things too. I certainly don't have a problem with enrolling myself in experimental protocols, because they're experimental protocols, they will help science, and who knows, that may be the magic drug. So I don't want mechanical ventilation. That won't help. But I do want an experimental protocol done on me. If alternative medicine, if there's little risk, I might consider some of the alternative medicine that is out there. That's not Laetrile from Mexico. I'm not talking about that. But I'm talking about something that has some scientific basis. But all through my life, I've done double-blind, randomized, placebo-controlled trials. But I don't have one anymore. So in order to try to have hope, what's wrong with hope? To take one of those is an alternative. And I am not going to say that alternative medicine is not a thing that should be done, because I think the FDA is way too slow in certain circumstances in getting a drug to the market place where it can be used for people who may have a problem like I have.
Roger, this plays right into a word that is frequently heard in medicine, and that's futility, the state that a patient may arrive at. But that seems like such a relative word. Should we be using different terminology here? Is this confusing us?
Well, let me describe futility. In the pulmonary and critical care community, we deal with this often, and it depends. Futility is when it is highly unlikely that there will be a survivor from the therapy that you're given. But that is a problem. Okay, let's say that you have a severity scoring system and it says that you have a 90% chance of dying. That means that there'll be 10 patients out of 100 who will live. Well, you can't determine which 10 are going to live. 10 are going to live, 90 are going to die. So are you going to not do something because of a 90% mortality rate, because you're going to get a 10% survival rate? So futility, you could say it's 95%, okay? Well, what is your threshold for futility? And I don't think we know that yet. And that is an ethical issue more than it is a medical issue. And that ethical issue will have to be looked at in our society, looking at economic issues, social issues, ethical issues, and futility issues. Another part of futility is the damage we often will do with iatrogenic disease. If we have someone who has a 90% mortality rate and then we start intubating, ventilating, dialyzing, we often will produce a mortality rate from iatrogenic disease greater than 10%. And I think those things are evolving with time, and we will have a futility index sometime. I think that the medical community will accept it sometime, not today. It takes a while for these things to be accepted, but futility will be part of the process someday And I think someday when it is known that you're at 95% mortality rate and your iatrogenic complication rate is 10%, let's say, you're not going to do anymore. And I think that's smart. I think that's smart. But I think it requires a tremendous amount of good people involving the religious, the ethical, all of the aspects of medicine at trying to determine this type of thing.
Well, clearly, the conversations that take place early in the course of a serious illness guide everyone who's involved, the patient, the responsible physician, the family. The advance directive is intended to promote these kinds of conversations. In my hospital, I believe that this is something that takes place during the admission process. The physician may never even be involved. What are your thoughts about advance directives, how they play into the whole subject?
Well, advance directives are very, very important. I think they should be done, and in most places now it is a hospital rule that you have to do that, and it's part of, you have to do it. You have to do this very, very early, and I'm very happy that is taking place. The problem is, if you'll look at some of the journals that are out there, and I can quote you one, JAMA, for example, they went to the physician, and the physician, over 50% of the time, did not know that there was an advance directive that had been signed by the patient. So there had been no communication whatsoever between the patient and the physician about the advance directive. And which advance directive you choose, I think, makes a very big difference, whether it's a power of attorney, or not, So I think it's a big issue, and I think the physician often is not involved, as you said, and I think that's a mistake.
Let me come back to the phrase that Kubler-Ross uses, death-denying society. Once again, how can our profession get these important topics into the public discourse before people even have a disease to work with? They've thought about it.
If you looked at the books that have been written on near-death experiences, there must be 10 or 20 books written on near-death experiences trying to understand something about what happens after death. So I think the public is well, first, they are very interested in the topic. They are interested because they know what's going to happen to them. And there are new resources available that are becoming available because people are interested in the topic. And most libraries have a lot about this now.
It almost seems as if the medical profession is behind the public.
I think so. I think if you look at who wrote the books, you don't see MD behind the name many times. You find this often people who have not had a medical background and have not ever seen a patient die, let's say, and not ever been involved in the process, which I think is okay too. There is a process that one gets there too. But the medical profession is involved with living. They're involved with living, and they haven't gone to the dying process, which is part of living. And when one realizes that it takes place in everyone, then the medical profession, that's one of the things the medical profession has to be involved in.
Well, there's another very important point that you've made in some of your writings, and I have to preface this because you have had such a brilliant and productive career in medicine and in clinical research, and you've written so many important articles. But you wrote something recently that made me think there is indeed a paradox. You are facing a serious illness and the possibility of death. But you have a sense of life that may be unprecedented. Let me read from your own words. I saw death more times than I can count, and I always thought death caused a collapse of the dying person inward upon themselves. The dying person appeared to be little more than a shrunken shell lying in a hospital bed. Physical collapse meant that there was a collapse of mental and spiritual being as well. I see now I could not have been more wrong. Share with us about this.
Well, what I mean by that is I wanted, from the perspective of someone who is going through the process, to say, this is the process that is taking place. This is where the medical community is at this time. And this is what might be done in the future that may help and alleviate the process in the future. So I had hoped that my writings would stimulate the study of the dying patient, so that dying is not as bad a process. I mean, when I looked through the classics, you can find many examples. Beth, for example, in Little Women, she just died, and her family was overjoyed that she died because she had no more pain. In hospitals now, we're hopefully giving more pain medication so that we have a peaceful death rather than the agony of what happened in the past. I think we know much more about that now. So I think it's very, very important to recognize that. And I just felt it was, while I was well enough, and I have been in the past well enough to write about this, that I shouldn't just be not doing anything. This is something that deserves one's attention, and is something that is very important, and something that I wanted to hopefully stimulate further conversation about.
Do you feel perhaps that this was indeed a special purpose?
I don't know. I really don't know. If I have helped patients in the future, then maybe there was a special purpose. And maybe it was more important than my septic work and my ARDS work and whatever. If nothing comes of this, then I don't think so. You can only judge by history, what is going to happen later as a result of certain actions. And I will not know that. I don't know that. We're talking about it right now, in front of pulmonary and critical care physicians. And these are the people who take care of people who are dying most of the time. So this is a time that of reflection that may be very, very important for that community. So this may be very, very important. But I'm not, I don't know if what I've done is important in doing it.
Well, I think your answer to my question is very gracious and also modest, but that's my opinion. A final theme that does come through all of your writings is this sense of graciousness, and this is what I see. And expressing thanks for some of the good things in your life. You would not have chosen this illness, nobody would, but thankfulness isn't something we talk about in medicine either. Do you think it's something that helps at this stage?
I think it's, as I said, I'm thankful that I didn't have a heart attack and die suddenly. I'm thankful I didn't have a stroke and die suddenly. I have many colleagues where that happened. And I would hope that my message to the pulmonary and critical care community that's out there that will see this tape is that sudden death will take place in a certain percentage of those people. And in a certain percentage, they will have a lingering process like me, and they'll have time to get their things in order, hopefully. I would challenge them to get their things in order right now. This is the time to get your things in order, because you may not have the opportunity to get your things in order otherwise. So that would just be my challenge to those that listen to this tape.
Well, Dr. Roger Bone, I am thankful, and I am thankful on behalf of the people who are listening to this tape, for your willingness to share something so close to your heart and your life, and I would predict that many people are going to take your words very seriously. Thank you.
Thank you, Claire.